6, and we want to welcome all of you. I want to welcome all of you in this particular meeting today. Again, as usual, we have been meeting every Thursdays, and we have nicknamed our meeting as Surgical Thursday, and we are learning about tendon injuries today. That's a topic at our hand. Remember, we are covering some topics around the module called hand surgery for general surgeons. Our colleague and friend, partner in crime, Professor Bill Schechter from the Alliance of Clinical Global Training is leading us once again today. Your host today is, as usual, Mugisha and Koronko from NetCare Foundation. I want to welcome Bill to start, and we as others are joining. You're welcome, Dr. Bill.
Okay, so good evening, everybody, and thank you for joining us. Let me just put the slides up here for a second. So just to remind everybody, we've been running a series of courses, and this course is hand surgery for general surgeons, and we've talked about anatomy extensively, and last week we had an entire session on infections of the upper extremity. So today we're going to get into the nitty-gritty of tendon injuries, and but before we do that, I just want to mention that next week we're going to have a guest lecturer. My friend Scott Hansen, who's a hand surgeon and is an expert in hand fractures, is going to join us and is going to give us a talk on hand fractures. And so at the end of that time, those of you who are attending should be able to manage most hand fractures and learn the various techniques, both conservative and interventional, for reducing and stabilizing hand fractures. So that should be a very interesting session, and I hope you'll spread the word and have all your friends join us so that we have a large crowd because he's doing us a special favor by spending an hour and a half with us next week. Okay, so having said that, the topic for today is flexor tendon injuries, and these are very, very interesting injuries, and it's challenging to get a good result for reasons that you already know about. The zone 2 injuries, where you have both the sublimus and profundus tendons sliding through the fibroosseous tunnel, and the key is to get a firm, solid tendon repair, but without adhesion, so that the tendon will glide. And we'll talk about various techniques to make that happen. I presume you can see the slides, Mugisha. Is that correct? Can you see it, Mugisha?
Yes, we can see it.
Okay, great. So what are the basic principles of tendon repair? First, flexor tendon repair. First of all, you got a flexor tendon injury. That has to be done in the operating room. You can't be doing that in the clinic or in your office or anything like that. You need to be in the operating room. You have to have a real anesthetic, either a general anesthetic, IV block, or an axillary block, some type of regional anesthetic. It needs to be done under tourniquet control. Remember, we talked about that before. Sterling Bonnell, one of the fathers of hand surgery, used to say, you can't fix a watch in the bottom of an inkwell. In other words, if the whole place is flooded with bleeding and flooded with blood, you can't really identify all the moving parts in the hand, because you've got a lot of anatomy stuffed into a small area. So you have to have tourniquet control. If it's a contaminated wound, the patient should you can consider cultures. I have to admit that I didn't usually do that. You have to have adequate exposure by making proper skin incisions. And most of all, you have to have atraumatic technique. You got to be very, very gentle, because remember, we're trying to minimize adhesion. The whole trick is to repair the tendon without getting the tendon stuck to the surrounding tissue, because then it won't move. And remember, wounds heal by fibrosis. Fibrosis is Mother Nature's glue. That's how wounds heal. But we want the fibrosis to occur between the two ends of the tendon, so we get a nice heal tenorrhaphy. But we don't want any adhesions between the tendon and the surrounding tissue, so that the tendon will glide smoothly. And that's easier said than done. Now, an ideal tendon repair, you'll have good exposure. You'll place your sutures. You'll get anatomic approximation of the two ends of the tendons. And the other thing is, you can't interfere with the blood supply of the tendon. Remember, the tendon is white. That means it's got bad blood supply. There's only one or two tiny vessels supplying the tendon, so that when we place our stitches, we have to pay attention to the blood supply. And I'm going to, later on in this talk, we'll talk about the modified Kessler suture, which is one of the standard tendon repairs, which gets good approximation. It gets a good purchase on the tendon, but it interferes minimally with the blood supply to the tendon. And we want to be able to have the tendon repair such that we can begin early mobilization, because we don't want the joints to get stuck. We've talked about that extensively. We talked about the position of function, and but also after tendon repair, we want to be able to passively, and some people do controlled active range of motion of the fingers, so that the joints do not get stiff. Aftercare is very important. Now, in terms of exposure, there are many different types of incisions, and you can see here. But this incision that's illustrated on the fifth finger is a good incision, a zigzag incision, which will allow you to open flaps and expose the underlying structure. Now, the importance of the zigzag incision is, as a general principle, you never want to have an incision, a straight up and down incision across a joint, because that may, when that heals, it may impair movement of the joint, or even cause a flexion contracture of the joint. So what you want, so when you want to make your exposing, if you've got some type of injury in a digit, you would like to make some type of zigzag incision like this. The other way to do it is to make a longitudinal incision either on the radial or the ulnar aspect of the finger, and then elevate a big flap like that. That's another way to do it. That's a fine way to do it. My preference was always to make a zigzag incision. Here you can see a zigzag incision over the carpal tunnel, and to expose what we call zone 5 and zone 4 flexor tendon injuries. We're going to talk about that in a moment. Now, how do you handle the tendon? And remember, we talked about how you have to be incredibly gentle and not grab the outside of the tendon, because that's going to create an injury in and of itself, which is going to create adhesions. When you grab the tendon, you'd like to grab it on the cut edge of the surface, because that's where you grab it with a clamp or whatever instrument you're going to use, and then you can work with it. But do not grab the side of the tendon with a clamp. All that's going to do is injure the tendon and create adhesions. Now, remember, we spent 2 hours or more than 2 hours on hand anatomy. And some of you were not there for the lecture, but that's okay. We were going to go over it again. But for those of you who were, you'll see it'll be easier for you to grasp this now, since you've been exposed to it before. So when thinking about tendon injuries, flexor tendon injuries, which occur on the volar surface of the hand, we divide the area of the hand into 5 regions. We have zone 5, which is proximal to the carpal tunnel, which is basically in the forearm. Zone 4 is under the transverse carpal ligament. In other words, a tendon injury within the carpal tunnel. Zone 2 is what used to be called no man's land. We'll talk about that in a moment. That's a tendon injury occurring within that fibroosseous tunnel, where you have both the sublimus and the profundus tendon gliding, one on almost entangled, one within the other. And the reason I went from zone 4 to zone 2 is zone 3 is that open space in the palm where you've got the tendons running, coming out from the carpal tunnel, but yet they have not yet entered the fibroosseous tunnel. And then zone 1 is distal to the middle phalanx, and that's where the profundus tendon inserts on the distal phalanx. So let's go over it again. Zone 5 is in the proximal to the carpal tunnel. Zone 4 is deep to the carpal tunnel. Zone 3 is in the mid palm. Zone 2 is in no man's land, tendon injuries in the fibroosseous tunnel. And zone 1 is the very most distal injury over the distal phalanx. Okay, now let's talk about the various zones and what you need to know about injuries in the various zones to make it easy for you to identify the injuries and fix them. So zone 5 injuries, like as we mentioned, are located proximal to the transverse carpal ligament. And they're usually associated with multiple tendon injuries. They can be associated with injuries to both the median and ulnar nerves. There's the median nerve, there's the ulnar nerve. And sometimes they are associated with vascular injuries, either to the radial or ulnar artery or both. So you've got multiple tendon injuries, potential for major injuries to the nerves, the median and ulnar nerves, and then an injury to the blood supply to the hand. Okay. Now, here's an important tip for those of you who are going to be dealing with zone 5 flexor tendon injuries, and that is the key to dissection in the volar forearm, proximal to the carpal tunnel, is the median nerve. You've got to identify and preserve the median nerve, which is right here. It's located right underneath the palmaris longus tendon, which you can see here. And why is this important? It's important because all the structures in the wrist, on the volar wrist, are located ulnar, on the ulnar side of the median nerve, with the exception of the flexor carpi radialis and the flexor pollicis longus. Let me repeat that. Every structure in the wrist that might need to be repaired is located ulnar to the median nerve, with the exception of the flexor carpi radialis and the flexor pollicis longus. So as soon as you identify the median nerve, you can go easily check out the flexor carpi radialis. You go deep and you can check out the flexor pollicis longus. You know, by the way, that the radial artery, we talked about this in the vascular course, the radial artery is located between the radial epicondyle down over here and the flexor carpi radialis tendon. So it's very easy to find the radial artery because you just go radial to the flexor carpi radialis tendon and it's right there. Everything else is ulnar to the median nerve. Now, let's go a little bit more proximal in the forearm. And you will remember from your anatomy, or maybe you won't remember from the anatomy, but we're going to reemphasize it, that in the forearm, the muscles and tendons are arranged in 3 layers. There's the superficial layer, which contains the pronator teres very proximally, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. Then there's the deep to that layer. There are the 4 sublimis tendons, and deep to the sublimis tendons are the profundus tendons, and the palmaris and the flexor pollicis longus. Okay. So here you can see what we're talking about. This is the brachioradialis here. Here's the pronator teres. Here's the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. So how are you going to remember this when so if you're a general surgeon like myself, you may not be doing this kind of work every day. If you're a professional hand surgeon, you're going to be doing this work every day. But if you're a general surgeon, you'll be doing this work occasionally. So how are you going to remember all this stuff? So here's the trick. If you put your left hand over your right volar forearm and spread your fingers out like this, the thumb is located in the approximate position of the pronator teres. The index finger is located in the approximate position of the flexor carpi radialis, the long finger, palmaris longus, and the 4th finger, the flexor carpi ulnaris. So if you're confused about the superficial layer and you can't remember it, no problem. Just stick your hand like that and it'll become clear. Okay, now let's look at the middle layer. Because sometimes somebody will get a machete wound or something like that across the middle layer, and there are all these cut pieces of tendon flying all over the place, and you don't know what's what. Now, how are you going to figure this out so you connect the right tendons? Well, you're going to know the distal tendon, which is which, very easily, because you're just going to pull on that tendon, and you'll see which finger moves. So you'll know which tendon is connected to which finger, right? But sometimes you can get confused with the proximal tendon because there are all these cut tendons. So here is our muscle wad for the flexor, the sublimis tendons. And here's how you figure out which is which approximately. If you put your hand like this and flex the long and 4th fingers, and you'll see that the flexor digitorum sublimis 3 and 4 are superficial to 2 and 5. Let me repeat that. Flexor digitorum 3 and 4 are generally superficial to flexor digitorum sublimis 2 and 5. So you'll know which tendon goes to which finger distally by just gently pulling on the tendon. And you will identify the 4 proximal tendons after doing a little dissection, because sometimes they retract a little bit to the muscles. So you have to do a slight amount of work to figure out what they are. And then once you got them exposed, the tendons to 3 and 4 are superficial to 2 and 5. That's the trick for identifying the sublimis tendons. Now remember that the sublimis tendons generally each come from an independent muscle wad. So that's why you get independent flexion of the PIP joints of the fingers. You remember that from our anatomy. On the other hand, the profundus tendons all arise, as you recall, from one big muscle wad. And they're generally arranged radial to ulnar, profundus 2, 3, 4, and 5. Okay, so here's another way just to re-emphasize this point. Here we are proximal to the carpal tunnel in the volar forearm. Here's your median nerve, okay? Radial to the medial nerve is one tendon. That's the flexor pollicis longus. Actually, there's another tendon up here, which they're not showing, which is the flexor carpi radialis. And then ulnar to the median nerve are the 8 tendons going to the 4 fingers. So we have 4 sublimus tendons right here. And as we talked about before, the tendons 3 and 4 are superficial, the tendons 2 and 5. And then below that, we have the 4 profundus tendons, which are all at the same level. So that completes our discussion of flexor zone 5. Does anybody have any questions or want to share any experiences about wandering around in flexor zone 5, maybe getting lost and how you figured it out, or what I said clear?
Yes, I would have a question, or should I just pop up my hand and write it?
No, you can go ahead and ask the question. Go for it.
Okay. So I was wondering about the tendons. You said 3 and 4 are over 2 and 5, and then there's 2, 3, 4, and 5 beneath those 2 layers. And like those tendons, what are they doing?
Okay.
Are they for not flexing, but the opposite, you know, for stretching the fingers?
No, that's on the other side of the hand. You missed the anatomy part. Well, but this will become clear. You see, there are 2 tendons which go to each finger. There's the sublimus tendon, which inserts on the middle phalanx and flexes the PIP joint. And actually that sublimus tendon splits and it inserts on both the radial and ulnar aspects of the middle phalanx. And then the profundus tendon goes up through the split, just like this, and then inserts on the distal phalanx. You'll see this in a minute when we get to zone 2 injury, and you'll see how it works. And that flexes the distal phalanx of each finger. So each finger has 2 flexor tendons: the sublimus, which flexes the PIP joint, and a profundus, which flexes the DIP joint. Any other questions? All right, hearing none, let's keep going. Now, zone 4 flexor tendon injuries are located within the carpal tunnel. And these are relatively uncommon injuries. And the reason that they're uncommon is you got that very, very thick transverse carpal ligament, which is protective of the underlying tendons and nerve. But if you do have a zone 4 flexor tendon injury, you have to be prepared to repair the median nerve, because remember, there are 9 structures, actually there are 9 tendons and 1 nerve which go through the which traverse through the carpal tunnel. The 9 tendons are, of course, the 4 sublimi and the 4 profundus tendons to each finger, and then you have the flexor pollicis longus, which goes to the thumb. And in addition to that, you have the all-important median nerve. And the median nerve is called the eye of the hand because it provides sensation to the radial aspect of the volar hand, and that's necessary for fine sensation, and also it also innervates the thenar wad, which allows opposition of the thumb. So it's called the eye of the hand, the median nerve. So in order to deal with a zone 4 flexor tendon injury, you must complete the division of the transverse carpal ligament. And there's a good way to do it that I learned early on in my training from my two mentors, one of whom unfortunately just passed away last week, I'm sorry to say, at an advanced age. But what they taught me to do was, again, identify the median nerve in the wrist, approximately, and then take a bandage scissor and slide the bandage scissor underneath the transverse carpal ligament on top of the median nerve, so that, and then take a scalpel and turn it upside down so that the blade is pointing upward, and then just very carefully slide that knife, cutting the transverse carpal ligament, but the knife is on top of the bandage scissor, so that there's no way that you can possibly injure the median nerve. And the point, my point is, you don't want to take a guy who's got a tendon injury to the hand, take him to the operating room, and then cut the median nerve, because now you've got a ruined hand. So you got to be very, very careful when you're dividing the transverse carpal ligament, that you do not injure the median nerve. And a good trick, for that, we just lost our my slides. How are we going to get that back?
Sir, could I ask you something?
Sure, go ahead.
If let's say we really cut the median nerve completely, how would we proceed? Like, I think this is the job for a neurosurgeon.
No,
but,
this is, you're not gonna. We're in Africa. There are no neurosurgeons. You have to fix that yourself. We're gonna get that. We're gonna get that. We're gonna talk about that. And when we talk about nerve injuries of the hand.
Okay, very well.
That's another lecture.
And is it possible to fully recover or a fully recovery of the hand, of the median nerve?
The full recovery is probably will not happen, but you can restore sensation, and you can often restore motor function, so that the hand will, so that the patient can oppose the thumb. You'll have sensation back. However, we never do it. We never do it the second time as well as Mother Nature does it the first time. Whether it's going to be as good as new, probably not. But you can have a very functional hand after a median nerve injury that's repaired properly. Okay, so here you can see that the transverse. This is of course a cadaver. This is the transverse carpal ligament is divided. Here we've got, they put a Penrose drain around all the nerves, and actually all the tendons, and this actually looks like the median nerve on top. I'm not sure, but the point is, in order to get complete exposure of the zone 4 injury, that is the carpal tunnel, you must completely divide the transverse carpal ligament, and you have to do that. When you do that, you have to make sure that you protect the median nerve so that you don't injure it. Okay. Now we're going to talk about the flexor tendon sheaths. And remember that this is a fibroosseous tunnel that goes from mid-palm until the distal phalanx. And it serves to protect the tendons. It provides there's synovium inside, which provides a smooth gliding surface, and the tendons have a vinculum, which we talked about in our anatomy lesson, which is basically like the mesentery of the intestine. The vinculum carries the blood supply to the tendon. Now notice that that these sheets for the second, third, and fourth fingers end in the mid palm. These sheets for the flexor pollicis longus tendon and the sublimis and profundus tendon of the fifth finger connect all the way into the wrist, as you can see from this cartoon. And we have another key concept regarding this fibroosseous tunnel, and that is the pulleys. There are a series of very, very tight fascial bands which go over the fibroosseous tunnel, which are called pulleys, and they function to prevent bowstringing of the tendon. And bowstringing of the tendon means that if you look at my fingers now and I'm flexing my fingers, the tendons hug the skeleton. So they come, whereas if we didn't have those pulleys there, when the flexor muscles in the forearm flexed, they would pull straight down, and you get like violin strings that you could pluck. But we don't want that. We want the tendons to be sliding right next to the digits, the bones, so that we have a smooth opening and closing of the fingers when we make a fist. So if you have an injury in zone 2, you may not be able to preserve all these pulleys, but you'd like to preserve, if possible, the A2 and the A4 pulley. What are the A2 and the A4 pulleys? Well, the A1 pulley is located over the metacarpal phalangeal joint. The A2 pulley is located over the proximal phalanx, and the A4 pulley is located over the middle phalanx. And I don't know if you remember that movie that we showed, but that was made by at Yale many decades ago, but it was a beautiful movie, and that showed how the fingers move within the and how the tendons move within the fibroosseous tunnel and the function of the pulleys. So here's an example of a tendon, say, repair without preserving the pulley, and you can see you get what's called bowstringing of the tendon when the PIP joint flexes, as opposed to maintaining the arch of the flexor tendon in flexion when the pulleys are present. And here's a cadaver dissection which shows preservation of the A2 and the A4 pulleys. Here's the DIP joint, here's the middle phalanx, here's the PIP joint here, and here's the proximal phalanx. Okay, now let's talk about zone 3 flexor tendon injury. Remember, zone 5 is in the volar forearm. Zone 4 is in the carpal tunnel. Now, zone 3 is that area located between the distal transverse carpal ligament right there and the proximal entrance of the fibroosseous tunnel. So here you can see that the tendon is exiting the carpal tunnel, and it's located in the mid palm, and it's about to enter this fibroosseous tunnel that we've talked so much about. Well, if you have a zone 3 injury, you know that you're highly likely to have an associated common digital nerve injury, because the common digital nerves run right here with the flexor tendons, and you may have a vascular injury to the transverse palmar line. So if you have a zone 3 injury, you'd like to repair both the sublimus and the profundus tendons if possible. So here's an example of a zone 3 injury. We know it's zone 3 because it's in the mid-palm. We know we've got both the sublimus and profundus tendons are cut because the finger is straight out. If the sublimus was intact, the PIP joint would be semi-flexed. So here you can now look what they've done from exposure here. You see they've opened up, probably cut a little bit of the transverse carpal ligament to get proximal exposure. You see they made a zigzag incision and to expose it. And here you can see the proper alignment of the fingers after they've repaired the tendon injury. Okay, so now we've reached the point where we want to discuss zone 2 injuries, and Maxim, this will hopefully give you a clearer answer to the question you asked before about the sublimus and profundus tendon. Recall, everybody, that each finger has 2 tendons which enter the fibroosseous tunnel. And remember that the sublimus tendon splits and inserts on both the radial and ulnar side of the middle phalanx. The profundus tendon is running deep to the sublimus tendon and then emerges through the split, what we call the desiccation of the tendon, and then it goes on distally to insert on the distal phalanx. And of course, we have the vinculae, through which these are very thin, very thin tissue, connective tissue, through which pass the blood supply to the tendon. Now, with zone 2 flexor injuries, associated digital nerve injuries are very common, almost routine, because the nerves are right there. So when you're exploring zone 3 and zone 2 tendon injuries, you also should explore the digital nerves, and if they're injured, repair them. And as I mentioned, we're going to talk about how you repair nerves in another lecture. Notice that the other point is that the sublimus and profundus tendons may well retract into the fibroosseous tunnel, and they can be stuck within zone 3, and then rarely can retract all the way into the wrist, into zone 5. So the question is, how are you going to find these tendons, and how are you going to bring them back so you can distally, so you can and repair the tendon, but yet maintain the fibroosseous tunnel so that you have this gliding surface where the tendons will glide. And that is the key, and I'm going to show you how to do that. Well, so let's say you've got this cut here, right? And they say the flexor tendon is cut, maybe the sublimus is cut as well, and you can't find the profundus tendon. And why can't you find it? Because it's retracted. And usually it's found right there. And why is it found right there? Because if you remember our anatomy lesson, I'm having a senior moment there. The lumbrical muscles, remember those are the muscles that flex the MCP joints and extend the PIP and PIP joints. We're going to talk more about that again when we get to extensor tendon injuries. They take origin from the profundus tendon. So if the profundus tendon is cut here and retracts into the palm, almost always it's stuck right there, because that's where and what's holding it? The origin of the sublimus muscle. So if you make a counter incision and open the flexor sheath, you'll usually find it there. Sometimes you can actually melt if the tendon is retracted, but it hasn't pulled all the way back to the palm. Sometimes if you just massage the palm over the flexor sheath, you can actually melt the tendon back and then grab it and pull it up. Okay, but let's say you can't do that. So you make your counter incision in the palm, as you see here, open the flexor sheath, and there's your tendon. So now what you're going to do is you're going to take one of these infant feeding tubes here, and you're going to pass it through the distal cut in the fibroosseous tunnel, and pass it down into the palm. Pull it out, and then you're going to sew the end of the tendon to this tube. And then you're just going to gently pull the infant feeding tube back, which will then pull the cut end of the tendon back. Now take a needle, like a 22 or a 23 gauge hypodermic needle, and stick it transversely across the tendon. And that will hold the tendon in place, and then you can do your tendon repair. Everybody got that? Any questions about that maneuver, about how you retrieve a profundus tendon which is retracted into the palm and bring it back through the fibroosseous tunnel, hold it in place with a hypodermic needle, and then do your tendon repair. Okay, everybody's clear on that? Good. Let's keep going then. Okay, this is basically just telling you what I just told you. Now, repairing the tendon meticulously is very important. And the first thing you have to start off with is, do you have the right needle? And do you have the right suture? So you would like to repair this with a monofilament nylon suture, and you'd like to use a P3 needle, which is a very small, sharp needle. If you're going to be trying to do tendon repairs with whatever needle happens to be lying around there, you're not going to have a good result, because these big needles that you're going to be using are going to chew up the tendon. Remember, I told you you have to be very, very gentle with the tendon. So if you are in a position where you're taking care of hand injuries and you don't have the right suture material, you got to do what you can to get it. And I'll be happy to help you with that if you need some help. But basically the best suture material to use for a tendon repair is a 4-0 monofilament nylon suture with a P3 needle. Now I'm going to show you in a moment the modified Kessler stitch, and we'll talk about some additions that the people use. But you want to get the tendons neatly approximated so that they're not ends sticking out, which can become caught on the flexor sheath. And then, if possible, if you can possibly repair the flexor sheath, that would be great. You can't always do it, but if possible, if you can repair the flexor sheath, that will minimize the amount of adhesion formation between the cut end of the tendon. Okay, so here is the look. If you look in the literature, you'll find many types of stitches to repair tendons. And each one has its advocate. But remember the principle that we talked about earlier in the talk. You want to preserve the blood supply to the tendon. You want to have a strong tendon repair that permits end-to-end opposition and permits early mobilization. And the Kessler stitch was which was described by Isidor Kessler, is a standard stitch which is widely used, and I use it almost exclusively. So let's not pay attention to the top of the cartoon, and let's focus our attention on the bottom of the cartoon here. Here you can see that they've taken this suture, they've gone through the cut end of the tendon, out of the tendon, taken the same stitch and gone transversely right across the tendon, around it, back into the tendon and out. And then they've done the same thing on the other side with a separate stitch. Into the tendon, out, around, now transversely across the tendon, out, back into the tendon and out, and then tied both tendons, tied the knots so that the approximating tendon, and notice that the knots are buried inside the tendon repair, so you don't have a big knot outside. Now, this is the modification. This is the original stitch that Kessler described, where the knot was outside, and you actually don't have to do this exact repair. You can achieve the same thing with one stitch by doing the following. You start inside here, out, transversely across, out, back inside, and then instead of using another stitch, you just go back here, inside, out, transversely, out, around and out, and then you'll tighten it up, and then instead of having two nuts inside, you have one nut inside. But this is an excellent way of doing a flexor tendon repair, or even an extensor tendon repair. We'll talk about that soon. And the idea is to get end-to-end approximation. Now, some people, in addition to doing that, will take a 6-0 suture and put a running suture around the epitendon to try to prevent because there are all sorts of little fibers here that can stick out and sometimes get caught on the flexor sheath. And so there are advantages and disadvantages to that. The advantages, if you can do it, which you neatly, which is not always the case, but if you can, that will prevent, part of your tendon repair from sticking out and getting caught on the sheath. The disadvantage is every time you put a stitch in, you're increasing the risk of ischemia. So I have to say, when I was actively doing this, I didn't routinely put a running 6-0 epitendon repair around it. I did it a few times. I wasn't really convinced of its efficacy, but there is some literature that suggests that you get a better result with the epitendonous repair. I think for our purposes as general surgeons, if you can get tendon to tendon approximation using this stitch, and it looks good, I think that, and you can achieve early mobilization, supervised mobilization, then I think and then I think we've done our job. All right, so we've talked about zone 5, zone 4, zone 3, zone 2, which is the most difficult, and just another word or two about zone 2 tendon repairs before we get into zone 1. Sterling Bennell, the great hand surgeon who actually developed the field of hand surgery after World War I, he thought that it was a huge mistake to do primary tendon repairs in zone 2, that is in the fibroosseous tunnel. And they used to have this term in World War I in the trench warfare where there was they called it no man's land, where you weren't supposed to go because you were likely to get blown up or shot. So he used that term for zone 2 tendon repairs, that this was no man's land, that you shouldn't do primary tendon repairs there. And his idea was that you should go back and then after the wound healed, and then put a tendon graft in there. Well, we now know that in fact, in most cases, with modern techniques, you can do zone 2 tendon repairs, that is tendon repairs in no man's land, and get a good result. But you have to be very gentle and use the principles that I outlined. Okay, zone 1 laceration. This is in the very, very distal part of the finger. And that's where the profundus tendon comes up through the desiccation of the, or the bifurcation of the supplementus tendon, and then goes on to insert in the distal phalanx. Here's the vinculum here. And when you examine this, here is an obvious flexor digitorum profundus tendon injury distal to the sublimus. How do we know that? We know that the sublimus is intact because the PIP joint flexes. And we know that the profundus is cut because the DIP joint does not flex. So now sometimes you can get faked out because sometimes the vinculum, the tendon is cut, but the vinculum has not torn. If that's the case, sometimes even though the tendon is cut, it will pull, and the vinculum is attached to the distal phalanx, and the distal phalanx will move, even though the tendon is cut because the vinculum is attached. So you be aware you can get faked out, but this tendon still needs to be repaired because eventually that vinculum will get torn away because it's very, very thin tissue. So just be aware of that when you do your examination. Okay, so here's the zone laceration. We talked about milking the tendon to retrieve the proximal tendon or making a counter incision. We talked about the need for good exposure, and we talked about how we can thread a feeding tube through there, suture it to the end, and bring it back. Same with zone 1. It's the same principle as with zone 2. You're going to hold it. You're going to hold the tendon in place with the hypodermic needle. Now, the problem with zone 1 injuries is you frequently do not have enough distal tendon left to get a good purchase. Whoops. So you can't get a good purchase. So what are we going to do? In this case, we can instead of suturing the proximal tendon to the distal tendon, because there's almost no distal tendon left sometimes, you just take the 2 ends of the suture, put them on straight needles, and bring them right out through the end of the finger. Now, in this case, some people like to bring it out through the nail bed. Personally, I like to bring it out not through the nail bed, but through the end of the finger. And then you put it over a button, but it has to be very, very well padded. You take some sponges, something like that, so that you don't get pressure necrosis on the end of the finger, and just hold it there. So zone 1 injury, the management of zone 1 injuries are similar to zone 2 injuries, except for the fact that you usually, with a zone 1 injury, can't suture the proximal to the distal end of the finger, it's a distal part of the tendon because the distal part of the tendon is of insufficient length to really hold a good suture. So in that case, you just bring it out and tie it over a button, a well-padded button, or whatever you're going to use. So to summarize our discussion of flexor tendon injuries, we talked about the 5 zones of tendon injury. We talked about in zone 5, the fact that the median nerve is the key to the dissection. You got to find and preserve the median nerve. Then you know everything is ulnar to the median nerve, except the flexor pollicis longus, the radial artery, and the flexor carpi radialis tendons. We talked about zone 4 injuries and the importance of carpal tunnel release and the overwhelming importance, whenever you're working with the carpal tunnel, of identifying and preserving the median nerve. If you cannot see the median nerve, do not cut. You've got to see the median nerve, and you've got to have it protected. We've talked about zone 3 injuries with their associated common digital nerve injuries and palmar arch injuries. We've talked about zone 2 injuries with their associated digital nerve and digital artery injuries, and the importance of preserving the flexor sheath and using and retrieving a retracted tendon using an infant feeding tube. Same principle with zone 1, except that you may have to, you usually have to use a pull-out suture to do the repair. And that, ladies and gentlemen, finishes our discussion of flexor tendon injuries. I'll be happy to entertain any discussion, and if not, we can start on extensor tendon injuries if you want, or this may be too overwhelming, and we can just stop there and talk about extensor. We're going to actually next week we're going to talk about hand fractures, and so we will talk about. We will continue our discussion of the soft tissue hand injuries in 2 weeks. Mugisha, what's your pleasure?
Yeah, I think we have a couple of discussions, and we continue with the extensor injuries next week. And I have a couple of questions that have been asked here. Number 1.
So maybe I can start off by asking, are you guys taking care of hand injuries? And if you're not taking care of hand injuries, is somebody else doing it, or you just, you just sew up, you just clean out the wounds, sew them up, and hope for the best? That's my question.
I don't know who will be able to answer. Mukuka?
Oh, yes. So here in Zambia at our facility, Ndola Teaching Hospital, with the surgeons, we actually do take care of the tendon injuries. We've had a couple of patients who presented with tendon injuries through exposure to sharp objects, and we've taken the opportunity to repair the injuries. But we didn't have prior knowledge of how to do the Tesla method. So you've highlighted a number of good points, which we will pick up and improve on our skills of tendon injuries. Otherwise, we have been exposed and we do repair the injuries.
Great, fantastic. Have you encountered a zone 2 flexor tendon injury in your practice? In other words, in the fibroosseous tunnel?
No, mostly the ones I've encountered are zone 5.
Zone 5. Okay.
Zone 5.
Now, where I work, many of the zone 5 injuries are suicide attempts. In other words, patients who are depressed or mentally ill try to commit suicide by slitting their wrists. So there were a lot of lot of median nerve injuries, less common ulnar nerve injuries, and a lot of tendon injuries due to that problem. Anybody else want to add to the discussion?
Yeah, I don't know, in our practice, but in our practice, zone 1 are very difficult to see. The majority of the patients that I have happened to repair tendons is zone 5 and zone 4.
Okay.
I think that is more prevalent in our setup.
Well, a lot of zone 2 and zone 1 injuries occur. You guys hear me?
Yes.
A lot of these injuries occur washing dishes. In other words, you've got all these knives and dishes, and it's under soapy water, and people are washing the dishes, and they don't see the very sharp knife, and then cut themselves. That's
All
it.
right. Yeah. Another concept that probably we discussed some in the last. Sifa Koinange, before I make my another remark, you're welcome.
Okay. Thank you so much, Professor, for these lessons. They've been very helpful, especially for me. Many times I've encountered head injury in my practice. And lately I had a zone 1 injury, and it was due to human bite. So I don't know how can I approach that one? Should I also like suture it in primary intention, or I have just to manage the wound, like in case of any dirty wound due to human bite, and how long can it take for that tendon to be repaired?
Okay, so that is a fantastic question, and we're actually going to talk about human bites when we talk about extensor tendon injuries. So I actually have never encountered a flexor tendon injury from a human bite, but I've encountered many extensor tendon injuries. And the reason extensor tendon injuries are more common is, somebody's out drinking usually, and then they get into a fight, and then they punch somebody in the mouth, and then the bite goes, the front tooth goes through the knuckle joint, the metacarpal phalangeal joint, cuts the extensor tendon and enters the joint. And that is a very, very big deal because of the terrible risk of infection. And so I am not speaking with extensive experience from zone 1 injuries, from flexor tendon injuries from human bites, because I haven't seen them. However, I've seen many human bites of the hand, and the basic principle is you want to irrigate it out. You do not, under any circumstances, want to close the wound, and you want to keep it elevated and put the patient on antibiotics that covers aerobic and anaerobic bacteria. And the reason that this is such a big deal is that let's talk about your zone 1 injury. What's the color of the tendon?
So it's whitish.
White. And so what does that mean about the blood supply?
Has got a very poor blood supply.
Blood supply. What's the color of the fibroosseous tunnel in which the tendon is sliding? White. Same thing, poor blood supply. So what you're doing is, when you get a human bite, you're injecting anaerobic and facultative aerobic bacteria into a closed space with no blood supply. And that is a setup for a disastrous infection, and which can lead to the loss of the hand, of the finger, can lead sometimes to the loss of the hand, and sometimes can lead to the loss of life. So so I would be, particularly if it's a zone 1 injury, what your defect is the inability to flex the DIP joint. And why on all of the things being equal, I'd like to be able to flex the DIP joint. I'd rather have a functional hand that's not infected, that can do almost everything, rather than have a disastrous infection. So what I would do is wash the thing out, keep the hand elevated, let the thing heal, and then go back a week to 10 days later when when I'm sure that there's no infection, and then do a delayed repair. That would be the way I would handle it. However, I'm admitting that I have no experience with flexor tendon injuries. Must be very rare. Sounds like this guy tried to bite off the end of the finger, the guy's finger. Whereas most of my human bites have been in the right over here, punching a guy in the front teeth. You want to make any comments based on what I just said? Do you agree with it? Now, by the way, you don't have to agree with me. And if somebody somebody on the call has a different opinion, speak up, because I'm not right all the time. I'm a human being like everybody else.
Yeah, my challenge was, I know that after human bites, you can't repair the wound primarily. You have to get it, to put the patient under antibiotics, and then to go back later and repair. But most of the time, you're going to find that that tendon has already retracted. But the way of doing it, the retrieval, and the way we have learned today, it's very helpful. So next time, we don't know which button are you going to use when we retrieval that tendon in zone 1 injury.
Good. So one thing is you've got about 2 weeks from the time of the tendon injury until you retract it. Because if you wait longer than 2 weeks during the muscle atrophies, and it often can be very, very difficult after 2 weeks to retrieve the tendon. So if that's the case, then you'll have to do it. Then you have to do a tendon graft, and that may be beyond the capability of the average general surgeon. But the average general surgeon ought to be able to do the kind of repairs we talked about today. So if you decide to wait, which is what I recommended, until to make sure you don't have a serious infection, you should try to go back within 2 weeks if possible, because if you wait longer than that, it may be very, very difficult to retrieve it unless the tendon is stuck. In other words, if the vinculum holds on, it doesn't retract into the palm, then you'll be able to pull it up easily. But if it retracts into the palm, if you leave it there for a long time, the muscle may shorten and you may have trouble pulling it up. Any other comments or questions?
Yeah, I think Sifa Koinange, she's very right that human bites are not supposed to be closed immediately. You have to wait until the infection clears up, because the human bite is quite toxic very much as far as the infection is concerned. The surgeon will now have to struggle at one point in time, accept that particular struggle of looking for a retracted tendon. Again, Prof, is there any role of splinting the hand after tendon injury, after tendon repair?
Well, thank you for asking that question, because I didn't really cover that in this lecture. Probably should have, but we talked about the splinting before. But aftercare is absolutely critical. So if you remember in the talks that we talked about splinting the patient with the wrist extended, the MCP joints placed. Now with a flexor tendon injury, you'd like the wrist to be more in a neutral position, because you want to take tension off of the repair. You want the so you want the MCP joints flexed, the wrist neutral, and so you'll have a dorsal splint keeping the hand like this. And then there are two methods of managing flexor tendon injuries. One is passive range of motion, and the other is controlled active range of motion. I don't know what your situation is, and I don't know what your patient's situation is. I managed my patients with passive range of motion. In other words, I would have them, a family member, or come into the clinic and just gently, very gently, put all the fingers in a range of motion, because you don't want them to get stuck like this. There's some literature that suggests that you get better results by attaching a rubber band to the nail and fixing it to the volar aspect of your dressing. You might be using a cast, and then have the patient extend the finger gently, and then the rubber band pulls it back. So there's a sort of semi-active range of motion where you're not, the patient is only extending against resistance, but not actively flexing. The flexing is passive with the rubber band. There is some suggestion in the literature that if you manage your flexor tendon repairs, particularly zone 2 flexor tendon repairs, with this method, you get a better range of motion of the finger than if you do it with passive range of motion finger. Okay, that might be true, but on the other hand, if you've got an unsupervised patient, particularly an uneducated patient, and you do that, they may actively extend and flex to, like this, and then pull your tendon repair apart. And I have certainly had 1 or 2 flexor tendon repairs be pulled apart by unsupervised patients who got a little too enthusiastic. So you have to balance. You have to look at your own practice situation. If you're working with a patient that is that's going to play by the rules that you set and do the right thing, then you can consider this using the rubber band technique. And I didn't include that in this lecture because I personally didn't want to encourage this kind of thing in a setting where the patients may not always follow instructions carefully. But if you have patients that you think are appropriate, you can do that. Otherwise, if you see the patient one or 2 times a week, or you explain to a family member who's got control what needs to be done, you can do this for a couple of weeks, and then usually by 4 to 6 weeks after the tendon repair, they can begin active range of motion. Did I answer your question, Mugisha?
Yeah, I think I answered it. Yeah, correct. Another comment from the chat box that I've received is, what if you get a failure of failed tendon repair? How often do you try to repair?
Okay, so in other words, so there's a couple of types of failures. One is you do the tendon repair, and then the thing dehisces. The tendon repair falls apart. So that's one kind of failure. Well, in that case, you can re-explore the wound and try to and see if it's possible to repair the tendon. Now, as I mentioned, these tendons are, if you lose substance or it gets chewed up, it looks like a dog's breakfast when you get there, you may not be able to repair it. And so in that situation, you might have to wait and then do a tendon graft later on. And that tendon grafts are usually beyond the skill of the average general surgeon. So that's one possibility. The other thing that sometimes happens is you get a tendon which is repaired but doesn't glide because of adhesions. And in that case, you can explore the patient. Now we're talking about a couple of months later, and do an adhesiolysis. Cut cut the adhesions, yet move the fingers under direct vision, see that the tendons are now gliding, and hope that the adhesions do not reform. And so since the tendon is now intact, you can actually begin active range of motion immediately after the tenolysis, where you're basically cutting the adhesions between the tendon and the surrounding tissue. And then hopefully you'll be able to maintain motion, although obviously if it formed adhesions once, it could form adhesions again. So those are the two situations where one is where you get a dehiscence of your tenorrhaphy, in which case if you can try to repeat the tendon repair if it's possible, or if it's a late loss of function due to adhesions, you can explore it, do a tenolysis, which is basically cutting the adhesions, and then hope that that will take care of the problem.
Yeah, so thank you very much. Maybe we should be coming to an end, although we have 8 minutes, unless there's someone with a burning comment or a burning issue, burning question.
Okay, well, thank you all, everybody, for attending. I hope you all have a wonderful evening. And then next week, as I said, we've got a guest lecturer. One of my friends who's an expert on hand fractures is going to talk to us about the techniques in managing hand fractures. And I hope you will encourage your friends to attend so that he has a quorum. And so I appreciate your attention and look forward to seeing you all next week.
Thank you very much all for attending, and thank you, Prof, for being available, for extending your knowledge to us, and we really appreciate. We are looking forward for another talk next week from a colleague and a friend who is an expert on hand fractures. So we are looking forward for that, and we'll shout out to many colleagues so that he feels his meeting fills up, and he has that feeling of presenting to many people. Thank you very much. Until then, goodbye.
Okay. Bye-bye, everybody.
Thank you, sir. Have a
Bye.
good day. Goodbye.
Bye.